సో ఇక ఈ కోవిడ్ విషయానికొస్తే ఐ నో దట్ యూ హ్యావ్ సమ్ థాట్స్ ఆన్ వాట్ వీ షుడ్ డూ టు ప్రివెంట్ సచ్ పాండమిక్స్ టు ఫేస్ సచ్ పాండమిక్స్ బెటర్ ఇన్ ఫ్యూచర్. ఈ ప్రస్తుతం హాట్ టాపిక్ ఏంటంటే ఇప్పుడు ఈ థర్డ్ వేవ్ అనేది ఎప్పుడు వస్తుంది, ఎంత సివియర్గా ఉంటుంది అనేది. దాని గురించి మీ ఏమైనా ఆలోచనలు ఉన్నాయా?
అంటే ఈ ప్రిడిక్షన్కి అంటే మనం సైంటిఫిక్గా వెళ్ళాలంటే అంటే ప్రిడిక్షన్ చేయొచ్చు ఎప్పుడు వస్తుంది, ఎంత వస్తుంది అని. సో ఒక 5 కీ వేరియబుల్స్ చెప్తాను. అంటే ఒకటేమో ఇప్పుడు ఆఫ్టర్ ది సెకండ్ వేవ్ అండ్ వ్యాక్సినేషన్స్ వాట్ పర్సంటేజ్ ఆఫ్ పీపుల్ హ్యావ్ ఎ ఇమ్యూనిటీ. So that is the zero surveys already started coming. So I saw at least 2 zero surveys published from Delhi and one WHO All India Institute of Medical Sciences. So zero surveys gives one idea. That the second is the surveillance, ongoing surveillance. ఈ ఎస్కేప్ అనేది అంటే ఇమ్యూనిటీ ఎంత టైం పడుతుంది. సపోజ్ లాస్ట్ ఇయర్ పాజిటివ్ వచ్చిన వాళ్ళు వాట్ పర్సంటేజ్ పీపుల్ గాట్ ఇన్ఫెక్టెడ్ అగైన్ ఇన్ ద సెకండ్. So that means that gives us an idea how long a natural immunity will last or how long a vaccine immunity will last. Because that is still unknown. I mean, the only 1 year ayindi kabatti the longest period we can say is 9 months now, whatever the scientific data from a natural infection. The third variable is the new variants, whether they escape the existing immunity. Because that is the unknown variable. Which is not in మన కంట్రోల్లో ఎంతవరకు ఉందంటే టు ప్రివెంట్ ఇన్ఫెక్షన్స్. బికాస్ యాజ్ ద వైరస్ మల్టిప్లైస్ ద మోర్ వేరియంట్స్ కమ్. సో ద ఓన్లీ మెథడ్ ఆఫ్ ప్రివెన్షన్ ఆఫ్ న్యూ వేరియంట్స్ ఈస్ ప్రివెంటింగ్ డిసీజ్ ఇట్ సెల్ఫ్, ద ట్రాన్స్మిషన్ ప్రివెంట్ చేయకుంటే వేరియంట్స్ వస్తాయి. సో ఇఫ్ ద వేరియంట్స్ కమ్, సో దట్ ఈస్ ద థర్డ్ అన్నోన్ థింగ్. దట్ మీన్స్ zero survey is a known thing that is in our control. The duration, we should closely have the surveillance. At least the last report I came across from ICMR was it's about a 3% reinfection rate. And in the vaccines also, slowly now we are gathering information. What is the reinfection rate after a vaccination? After 1 dose of vaccination and after 2 doses of vaccination. So our data close surveillance also for us to make a dynamic projection, because we cannot really project in a single spot. The fourth is the drugs which are coming up. Some of the new drugs which are coming up in the newspapers also we are seeing. Along with vaccines, new drugs are coming up. New antiviral drugs are coming up. One is repurposed drugs. Most of the repurpose is over now. So unless the new drugs come. So that is another variable which might influence your prediction of third wave. The fifth variable is our social behavior. So what percentage of people are having COVID appropriate behavior? So these are the 5 variables, I would say, which can give us a rough idea of a third wave or fourth wave. The size of the third wave and the fourth wave again depends upon what systems we have, say, at a district level. So is the district is having a close surveillance of positive cases? Are there enough testing is happening as per the test positivity rate? It should be less than 5%. That enough testing is happening. So do we have a cutoff points that if positive cases in a district cluster exceed this number, do we increase our containment strategy? So the preparedness of the system to prevent a surge is the most critical thing. So at the district level easy ga cheyochu, district level, even the PSC level, and we should decentralize it. We should not blame the central government for everything, because this is a state responsibility. Health is a state responsibility, and after one wave they should have put all these systems in place. They never put a system in place. They happily listened to the center, and when suddenly they caught off guard, they started blaming the center. So these things can may not eliminate the third wave. Suppose if the zero survey data in Delhi is true, where it is 80%, that means they already reached the herd immunity. The only way next wave can happen is if a new variant which escapes the existing immunity then you have a next wave. So best is to assume that next wave is inevitable because of all these unknowns. See, always when you plan for the worst case scenario, I mean, in business, you are from MBA, so you understand.
Yeah.
The worst case, if you plan, prepare for the worst case scenario, you will never go wrong. I mean, that is what the risk mitigation strategy. The surge, I mean, because now we have what is the peak stress the system has undergone in the second wave. Suppose you assume that the next wave also is at the same level of surge in the worst case scenario, or you can look at the scenarios at the same level of surge or double the level of surge. And at a district level, if you map the entire infrastructure in the district, both public and private, just how many hospitals are there, how many beds with oxygen, how many beds with ventilation, how many beds with dialysis machines, how many doctors capable of managing a ventilated patient. So what the government was doing is only they were focusing on their infrastructure. No, as a health system, they are responsible for the entire infrastructure. So that is what a register should be there. In fact, one of the NDHM one pillar is national registers of your infrastructure, the resources basically. How many beds are there? How many doctors? How many nurses? In a dynamic register in a standardized fashion. So we don't have to struggle for information. At a click of a button, you know how many beds are there, how many are occupied in a normal times, what is the occupancy rate, and so then we know what is the spare capacity. And based on your surge projections, you can estimate what is the extra capacity you require. Then you can have a strategy of how to create that extra capacity. For example, today that capacity is occupied by non-COVID cases, out of which some of them can be managed at home. So you can have a plan what to do with non-COVID cases and what to do with COVID cases. So my recommendation is that this is not a rocket science; it is a simple management science, and it does not require complicated epidemiological statistical analysis for this. The basic indicators, I mean, what are really feasible. So those basic indicators we can have that, and using those basic indicators, we can have a planning system. Only thing is how to train the district level people to have this capacity to manage. So that has to be invested in. In fact, in the next 1 month, 2 months, we have to invest in training these district officials in a more robust way of predicting as well as preventing and
Yeah.
managing the surge, a
Yeah.
potential surge.
Monitoring the resources available in both the public and private
That
sectors.
is important, and engage them in all the planning. That was one of the mistake in the both the ways. We never engaged the private sector enough. Right? We never took them into confidence. We never discussed about what it will cost to manage a COVID case for them from their cost structure. We only said you don't should not charge about this. I mean, with what knowledge a high court judge is able to pass a judgment, I don't understand that. Does the judge have a understanding, or is he taking expert opinion how much a hospital costs to manage a COVID case? For example, in DDH, I costed it. I was losing 10,000 for every case that I am managing, following government rates. Strictly government rates, I was losing. So I was willing to lose because it is a rare opportunity to provide service. But every hospital may not have the same mentality because they have to sustain themselves. Okay. So this is the engaging private sector is a critical policy imperative as a whole systems approach, and mobilizing the entire machinery of the government, not just the health machinery, because it is a social crisis. It is not. So how do you address people's requirements, financial requirement, their food requirement, their job uncertainty requirement, their sick leave requirement? So we are not addressing in a systems way. We are only saying oxygen is not there. Okay, I will put multiple. So now you have capacity for next 100 years. Okay. Same thing
Vrishti
happened with
anavrishti,
PP.
like
Yeah, same thing happened with PP. Right? We had nothing in the beginning of last pandemic. Now we have enough surplus to serve the entire world. Actually, so that is what we call the band-aid response. Okay, the transactional attitude of planners. We don't see that the leadership and the management skills uh, in people who are interested with managing health systems. Okay. My diagnosis, I mean, if I'm the doctor for health systems, my diagnosis is that is a singular diagnosis. We have enough money, we have enough resources, we have enough drugs, enough people, we have enough doctors. I mean, if you ask many doctors, how many doctors are actually seeing 30 patients a day? Many people, many doctors may be unemployed or just sitting idle. Many hospitals are unoccupied, 50% occupancy. So let us not keep on crying about our poor infrastructure and other things. We have poor leadership and management of health systems.
సో మీకున్న డేటా ప్రకారం ఇప్పుడు తెలుగు స్టేట్స్ వరకు వస్తే కనుక ఈ స్టేట్స్ ఎంత ప్రిపేర్డ్గా ఉన్నాయనుకుంటున్నారు నెక్స్ట్ వేవ్ ఫేస్ చేయడానికి? కానీ ప్రోటోకాల్స్, ఆ సిస్టమ్స్ గవర్నమెంట్ సైడ్ నుంచి రెడీగా ఉండటం అనేది.
అంటే యాజ్ అన్ అవుట్ సైడర్ అబ్జర్వ్ అంటే బికాస్ అంటే మాకు చాలాసార్లు లోపల యాక్సెస్ ఉండదు.
యా
హౌ ద డెసిషన్ మేకింగ్ ఈస్ హ్యాపెనింగ్, వాట్ ఈస్ దే ఆర్ మానిటరింగ్, what data they are sharing transparently and what data they are not sharing. So, given all those limitations, as an outsider, I can comment that both the states are not prepared. Because there is, I don't see some of the decisions that happened, both in response to the first wave and the second wave. I don't see a professional approach to planning. I only see a reactive approach to the decisions, whether it is a lockdown decision or whether it is a testing decision, or not allowing private labs to test, or not allowing private hospitals to take care COVID care. So all these things, at least as an outsider with an experience in management, I can say that it is not a professionally managed response.
అదే మీరు చెప్పినట్టు ఇంతకుముందు ఇప్పటికీను ఈ ప్రభుత్వాలు ప్రైవేట్ ఆర్గనైజేషన్స్ని యాక్టివ్గా ఎంగేజ్ చేయడం అనేది ప్లానింగ్లో కనపట్టలేదు.
ఇట్ ఈస్ వైటల్. అంటే మన మిక్స్డ్ హెల్త్ సిస్టమ్. ఇన్ఫ్యాక్ట్ మీరు వరల్డ్ WHO బిల్డింగ్ బ్లాక్స్ కాన్సెప్ట్ తీసుకుంటే వన్ ఆఫ్ ద కీ బిల్డింగ్ బ్లాక్ ఈస్ లీడర్షిప్ అండ్ స్టెవర్డ్షిప్. సో ద స్టెవర్డ్షిప్, I mean not regulation. The word used is stewardship. The stewardship is how you steward the private sector. So one of the critical responsibility of the governance of the health system is the stewardship over the private sector, which is an equal responsibility. So that is a critical gap I see in our government's response, both at national and central state levels, are that stewardship is lacking. There is a huge divide between the public and private as far as healthcare is concerned. Other industries, there is a close collaboration is there. I mean, when we looked at the pharma industry, there is a close collaboration. But the health sector, somehow, the Ministry of Health has secluded itself, saying that we have nothing to do with the private sector.
రైట్. సో యాజ్ ఇండివిజువల్స్ మనం చేయాల్సింది ఏంటి అనేది, అంటే టు బి బెటర్ ప్రిపేర్డ్ ఫర్ ద నెక్స్ట్ వేవ్ అనేది?
You asked the right question. ఎందుకంటే in fact, the responsibility starts with the individuals to really take care of it. One is, the first and foremost is, if they get a chance to get vaccinated, they should get vaccinated. That is the one. Second is, they continue face mask until the WHO declares that the COVID pandemic is over across the world, not in your country or in your state or in your city. Hand sanitization, of course, goes with the masking, but the masking is the most essential. And wear the mask in a right fashion, not hanging in the neck actually. Okay, so the right fashion. And if they're working in closed air conditioned spaces, wear the double mask, which is cost effective. That means surgical mask inside and a cloth mask outside. Because cloth mask, you can wash it and then do that. And surgical mask, which is cheap, you can dispose it out. I mean, this is a poor man's protection of N95. Right. N95, everybody cannot afford it. So this is a poor man's protection in closed spaces. In open spaces, surgical mask is enough or a cloth mask is enough. So this is the second thing that I would suggest. The third thing is, any element of suspicion or exposure to a COVID case or any syndromic suspicion, they should get tested. They should not be worried that They will be isolated. They have to stop going to the office. So that some people cannot afford to stay at home. That is what is coming up. In fact, a lot of workers, they are not disclosing that they are having flu-like symptoms because they're afraid that they will be put up in the room.
Right. They lose their livelihood.
Yeah, so so where they can do, at least they should get tested and they should stay at home, get isolated so that they're not exposing to other people. Yeah, at individual level, these are the things. And finally, individual level, they should plan their finances for a eventuality. I mean, see, if you are infected, then 10% chance you get hospitalized. If you are hospitalized, another 5% chance that you may get a ventilator. So, given all these unforeseen requirements, best is they should get insured if they don't have any insurance for not only COVID but future healthcare cost. I think people have realized, even the upper class, have realized that they can't afford a medical emergency. I mean,
Right.
today modern medicine can do anything. I mean, I can make the patient live for 1 year. You have ECMO so that you have heart and lung machine, and we have implantable left ventricular assist devices which can be there for 2 years. So we can run the kidneys. So we can manage the patient. But what we cannot manage is who is going to finance it. So the only way is that people mindset should change. That they should protect themselves through health insurance, especially against emergencies and major illnesses. So
Mm.
it's never late. I think if the government is covering, it is okay. Even if government is covering, at least they should know what it does not cover. మన దగ్గర ఆరోగ్య తెలంగాణలో ఆరోగ్యశ్రీ it did not cover COVID. I mean, the whole purpose of health insurance was to cover this type of catastrophic expenses. But so this is a classic example that who is deciding on these things, on what basis that Arogyasri should not cover COVID. Okay, so it's a classic example of absolute ad hoc decision making.
రైట్. సో మీరు చెప్పిన వాటితో పాటు ఇంకోటి నేను కూడా యాడ్ చేద్దాం అనుకుంటున్నాను. ఏంటంటే సాధ్యమైనంత వరకు ఇప్పటికి కూడాను అవసరం ఉంటేనే బయటికి వెళ్ళండి, లేకపోతే ఇంట్లోనే కూర్చోండి. ఈ సెకండ్ వేవ్ అయిపోయింది, థర్డ్ వేవ్ ఎప్పుడొస్తుందో ఇంకా తెలియదు కాబట్టి విహారయాత్రలకు వెళ్ళటం, పెళ్ళిళ్ళు, ఫంక్షన్స్, పార్టీయింగ్ ఇదంతా తగ్గించుకోండి అనేసి.
అవి ఆల్రెడీ స్టార్ట్ అయ్యాయి. And unfortunately, the people's memory is very short. Okay. So already, and we are seeing already people are planning for large marriage gatherings, and they were restricting at 200 people. Suddenly, they want now 2,000 people. Yeah, people will never learn. That is the problem.
ఈ చూడపోతే కనుక ఇలాంటి వైరస్లు ఇంకా ఫ్యూచర్లో కూడా వస్తూనే ఉంటాయని తెలుస్తుంది. కాబట్టి అంటే do we have to actually change our behavior permanently in certain way for the coming years అనేది?
Preparedness ki, and if look at overall thing, and at a system level అయితేనేమో we have to strengthen our health system in the areas that we mentioned: primary health care or financial protection, health information, human resource for health. So those 6 building blocks we have to strengthen. That is the first essential. I mean, the base essential for basic even the normal health systems. Second is we should have a totally revamped surveillance system. Now, with the digital technologies and with the big data analytics, we can easily have a more robust, more dynamic, more current surveillance system. Because that is how you can pick up a unusual pathogen, something unusual presentation immediately, even before it spreads. I mean, in the last 2 decades only, you have series of pandemic potentials, starting with your SARS-1, then MERS, then H1N1, then Zika, then Ebola, then Nipah. We are not listening to them, actually. So at least the only thing we needed COVID to change. But so that is the second thing, Andy. The third thing, as I mentioned, uh, the worst case scenario, that means the capacity planning for the worst case scenario. I mean, which is against the principle of efficiency. Efficiency is just in time. Whereas worst case scenario is you should have a stockpile of critical capacity. Not everything, but stockpile of critical capacity. So that is the third thing. And the fourth thing is the investment into the newer, apart from the digital technologies, the molecular technologies. Because your ability to diagnose a new novel pathogen within 24 hours is possible today with molecular diagnostics. Okay. So that should be invested in. In fact, I think in the budget they announced of creating more the diagnostic labs, the public health diagnostic labs, to diagnose some of these unusual pathogens. At an individual level, I mean, if we, I wrote an article earlier, and the face mask should be the condom of public health. I mean, just as condom prevented HIV and sexually transmitted diseases, the face mask will prevent all inhalable pathogens and pollutants.
Yeah.
So you can prevent significant respiratory illnesses, both due to the pollution and also due to the viruses, microbes. So that is another thing that we have to be. The third thing is one health concept. We are not just human beings alone. The animals that we live with, the animals that we breed, the wild animals that we are interfacing with the human. So we have to become conscious about that. That it is not just about like what antibiotics we are giving to chicken, right? So that is leading to antimicrobial resistance.
Mm.
And in the next 20 years, antimicrobial resistance is going to be the biggest public health problem, responsible for millions of deaths, because we don't have any antibiotics. No pharma company is investing into new class of antibiotics. Uh, yeah, so I think there are, in fact, I drafted a 9 point article
Okay.
for preparing ourselves for the future, not only the pandemics, but various crises which are likely to come because of the climate change, because of the human, the, the migration arising out of the conflicts. So that is where, I mean, in fact, if you look at our in order logo, uh, st- strengthen systems to secure health.
Okay.
Okay, so there
So,
is a health system strengthening component is there, and security is resilience. So one is that means you make your health system strong and resilient. So resilience is against a unknown crisis.
right, right.
I mean, Indians are highly resilient. I mean, because that natural evolution that we had, we are resilient, but we can be more resilient with the proper planning. I mean, we don't have to lose lives to become resilient. That's only.
సో మీరు చెప్పిన ఈ యాంటీ మైక్రోబియల్ రెసిస్టెన్స్ గురించి క్విక్గా అంటే మనం తినే విధానం కూడా ఏమన్నా ఆహార పదార్థాలు మారాలంటారా క్విక్గా అంటే ఆర్ యూ సజెస్టింగ్ దట్ వీ షుడ్ స్విచ్ టు వెజిటేరియన్?
అలా లేదండి. అంటే ఇప్పుడు బేసికల్లీ ఏందంటే ఇప్పుడు పెస్టిసైడ్ యూసేజ్ మెథడ్స్ కానీ, ఇప్పుడు మీరు ఫార్మా అన్నారు కాబట్టి ద ఫార్మాస్యూటికల్ ఎఫ్లూయెంట్స్ how they are breeding AMR. Then animal husbandry, where the antibiotics are being used, how they are breeding. So it's not just the misuse of antibiotics in the clinical medicine. There is a whole, I mean, the whole of ecosystem approach we have to adopt. There is no difference between the vegetarian and the non-vegetarian as far as, but if we are able to have a synthetic meat without breeding the animals, because the biggest contributor to the environmental pollution in terms of the carbon dioxide and the other pollutants is the industry of beef industry,
రైట్.
right? Yes, I mean, there is a case for that in terms of the climate protection. There is a case for judicious use of pesticides and the antibiotics. I mean, we talk too much on the clinical side about antibiotic stewardship, but we never talk about what is happening in the animal husbandry and the pharmaceutical pollution effluent
Right.
systems, quality systems.